Welcome to the Deep Dive, where we take complex source material and distill it into the insights you need. Today, we are going right to the heart of the matter, literally. We're diving deep into cardiomyopathy, or CM, so the primary diseases of the heart muscle itself.
It's a really vital topic because cardiomyopathy, it's heart failure driven by a muscular impairment, not just plumbing issues.
Right, not a blockage.
Exactly. And the definition is key here. We're talking about impaired function, whether it's, a weak squeeze, which is systolic, or port filling, diastolic. That is not caused by the usual suspects.
Like ischemia or high blood pressure.
Right. Or a faulty valve. It's the engine itself that's failing.
That makes perfect sense.
Yeah.
So if the engine, the myocardium, is the problem, where's the weakest link? What part of that muscle is under the most stress?
Well, what's so fascinating here is that the structural failure, it often begins at the microscopic level, specifically the sarcomere.
The sarcomere.
Yeah, just think about the physics of it. The heart muscle is constantly flexing, right? It's shortening and lengthening 60 to 90 times a minute every single day, your whole life.
That's a staggering workload.
It's relentless. And that mechanical stress means the sarcomere, the actual contractile unit, is the single most vulnerable spot. Any defect here, structural or functional, is what ultimately forces the heart to remodel.
By remodeling, you mean getting either massively thick or stretched out.
Precisely. Hypertrophy or dilation.
Okay, so let's unpack how that failure translates into what we see clinically. You mentioned the two primary ways it shows up, the weak squeeze and the stiff heart.
That's right. Systolic and diastolic dysfunction. And if we look at the source material, the three main types of cardiomyopathy align perfectly with which structural component fails.
Walk us through those three buckets of failure.
Okay, first, if the actual sarcomere protein, so the tiny machines doing the work, if they're mutated, we often see a chaotic, almost overly strong contraction. That results in hypertrophic cardiomyopathy, HCM.
So HCM is a muscle that's trying to grow too thick, too fast, and it's disorganized.
Exactly. Then second, if the support system fails, specifically the cytoskeleton proteins like dystrophin or titin, the entire myocyte loses its anchoring. It stretches.
And that leads to?
That leads us to dilated cardiomyopathy, or DCM.
Okay. And the third type?
The third is when the space around the cells, the extracellular matrix, gets choked or stiffened by, foreign material or just excessive fibrosis. That's when we see restrictive cardiomyopathy, RCM.
Let's use HCM and RCM as quick contrast points because they really highlight the different ways a heart can fail. So with HCM, we have these sarcomere protein mutations, thick walls, and this specific pattern called myofiber disarray.
Yes, and the paradox of HCM is that these sarcomeres are hypercontractile. They have increased strength, but because the walls are so thick and stiff, the ventricle can't relax or fill properly.
And the high-yield clinical clue there is the devastating risk of sudden death in young athletes.
That's the one. Now, RCM is really the opposite failure mechanism.
How so?
Well, in RCM, often from diseases like amyloidosis, the contractile machinery itself might be fine at first, but the matrix around it is so stiff, the heart just cannot expand. It's like trying to fill a concrete vase.
So it's a filling problem, a diastolic problem.
A severe diastolic problem.
Yeah.
And a critical clinical flag for you, RCM patients often show signs of right heart failure, swelling, liver congestion, all because that right ventricle also stiffens and can't accept blood, even if the ejection fraction looks okay initially.
That distinction is so key. RCM is stiff, HCM is thick and aggressive, and that brings us to dilated cardiomyopathy, DCM. DCM.
That's right.
It's structurally and functionally the heart's most common failure mode. People often call it the floppy balloon problem.
And that's a great way to think about it. But what's critical to grasp is that DCM isn't just one disease. It's the final common pathway. It accounts for something like 90% of all cardiomyopathies.
Right. And that's the puzzle we need to solve. Why do triggers as vastly different as, say, chronic heavy drinking, a common virus, chemotherapy, or even a genetic defect?
Yeah.
Why do they all lead the heart to fail in the exact same way?
That is the core mission.
So we're looking at a condition where the heart's chambers, especially the ventricles, they just dilate, they stretch out, they get weak, and they lose that ability to pump effectively.
That's systolic dysfunction.
Yeah, that's systolic dysfunction, which you can measure with the low ejection fraction.
Yeah.
Typically 40% or less.
And our source material today is really designed to give us crystal clear insights into this mechanism. We're going to distill the highest impact facts about the causes, the markers, and the clinical implications of what is basically a structural disaster.
And the one concept that ties this whole mechanical failure together is eccentric hypertrophy. So let's jump right in. Let's unpack that. What does it physically mean when the heart becomes ballooned and baggy?
It means the entire ventricular cavity is stretching, its radius is increasing, but at the same time, its walls are getting thinner, and this is all happening at the cellular level.
Right.
When the heart is under chronic volume stress, when blood is constantly backing up because of poor pumping, it tries to adapt. It does this by adding more contractile units, or sarcomeres.
Which at first sounds like a good thing. More contractile units should mean a stronger heart, right?
It would if they were added the right way, but in DCM, the key is they are added in series.
In a series.
End to end. So imagine adding links to a chain to make it longer, not thicker.
Ah, I see.
This process elongates the individual heart muscle cells, the myocytes. It increases the chamber length and radius, which is dilation, but it comes at a very steep cost.
Yeah.
Thinning the ventricular wall.
So the heart is basically making a self-defeating structural choice. Why is that making the chamber bigger and the walls thinner? Why is that a recipe for disaster from a pure physics standpoint?
Well, it all comes down to Laplace's law.
Right.
It governs wall stress, and wall stress determines the oxygen demand of the heart muscle. The law basically states that wall stress is proportional to the radius of the chamber and the pressure inside, but it's inversely proportional to the wall thickness.
Okay, I see exactly where this is going. In DCM, you increase the radius, which increases stress,
Schematically.
and you decrease the wall thickness, which increases the stress even more.
Exactly. Wall stress skyrockets. This massively increased stress means the heart muscle needs to consume far more oxygen just to try and contract. And since the heart's blood supply, the coronaries, are on the outside.
The inside layer suffers first.
Yeah. The subendocardium. It's the first to suffer from this high demand. This whole process, this mechanical death knell, often leads to subendocardial ischemia, which just accelerates fibrosis and damage. It's a vicious cycle of dilation, high stress, and more pump failure.
So the heart is literally killing itself by trying to adapt. It's a huge insight. So to really lock this concept in, we should probably contrast it with the other major type of cardiac remodeling.
We have to. We must contrast it with concentric hypertrophy.
Okay.
That happens in pressure overload states like chronic hypertension or aortic stenosis. In those cases, the heart adds sarcomeres in parallel, side by side.
So it's making the wall thicker.
Right. That addition thickens the walls, makes the cavity smaller and stiffer, and that results in diastolic dysfunction. The heart can't fill properly. So, to put it simply, eccentric is DCM, volume overload, thin walls, systolic failure. Concentric is pressure overload, thick walls, and diastolic failure.
That distinction is so important. Okay, let's connect that physical mechanism to what you would actually see in a patient. What is the classic presentation of a heart that's become too floppy?
Well, the typical vignette is a younger adult coming in with classic signs of low cardiac output and congestion. So shortness of breath, profound fatigue, peripheral edema.
And on the exam?
On the physical exam, because the heart is so huge, the point of maximal impulse, the PMI, which is usually felt near the midline, it's displaced way out laterally.
And this is where we get to the sounds.
Sure.
If you have a massively dilated floppy ventricle, you're going to hear that S3 gallop. Why is that sound so specific to DCM and systolic failure?
The S3 is the audible indicator of profound volume overload. It happens early in diastole, the relaxation phase, when blood rushes from the atria into the ventricles. And because the DCM ventricle is so large and compliant, the blood decelerates suddenly, causing the ventricular wall to vibrate. It's the classic blood splashing into a floppy bucket analogy. It just screams massive volume problem.
I love that visualization. And this structural failure, it also causes secondary problems, which are crucial for diagnosis. You're saying the valves themselves are normal, but DCM messes up their function.
Exactly. This is a key point. We see functional mitral regurgitation, or MR, and sometimes tricuspid regurgitation. The physical dilation of the left ventricle stretches out the valve ring, the mitral annulus, and it pulls the leaflets apart.
So they can't close properly anymore.
They can't. Even though the leaflets are structurally perfect, they can no longer reach each other to seal the chamber. They lose what we call coaptation. And this just dumps more volume back into the atrium, which of course compounds the whole volume overload problem.
It's just another one of those devastating cycles. So when we turn to diagnostics, the chest x-ray must be a huge clue.
Oh, it's a major clue. The heart is huge, often called globular or balloon-shaped, and you might see signs of fluid backup, like curly B lines. but the echocardiogram is the gold
What
standard.
was that shows?
The echo confirms the biventricular dilation, and crucially, it shows global hypokinesis.
Global. Why is it so important to highlight the word global?
Because it immediately differentiates DCM from ischemic cardiomyopathy. In ischemic disease, the wall motion problem is typically regional, localized to an area that's supplied by a blocked coronary artery. DCM affect the heart muscle everywhere all at once.
I see.
And of course, the echo confirms that severely depressed ejection fraction, usually below 40%. The ECG is less specific, but you often see electrical strain, like a left bundle branch block, or even atrial fibrillation from the massive atrial stretching.
All right, now we get to the part that really drives home this final common pathway idea. The sheer variety of causes. The list is huge, so let's stick to the highest impact ones. Maybe use that mnemonic, ACT-HIV.
Yes, ACT-HIV is perfect. Alcohol, Coxsackie-B, toxins, hemochromatosis, idiopathic familial, and valve disease. Let's run through these essential vignettes.
Let's start with the toxins. Alcohol abuse is the poster child here, right? It's the most common reversible cause.
It absolutely is. We're talking about long-term heavy consumption. This results in direct cardiotoxicity from ethanol and its metabolite, acetaldehyde. They cause massive mitochondrial dysfunction and oxidative stress. They just kill myocytes.
And the key takeaway for management is that reversibility.
Yes, because it is toxic and metabolic, if the patient can achieve strict, sustained abstinence from alcohol, there is a significant chance of partial or even full reversal of the heart failure. That makes early diagnosis absolutely critical.
Okay, next up, the classic infectious cause, Coxsackie-B virus.
This is the quintessential infectious pathway. The story is a young, otherwise healthy adult who gets a really nasty flu-like illness, recovers a bit, and then weeks later comes back with new onset heart failure, shortness of breath, and that signature S3 gallop.
And the damage is twofold.
It is.
Yeah.
You get direct viral destruction of the myocytes, and then you get a powerful subsequent immune-mediated inflammatory attack that just destroys what's left of the muscle.
We also have to talk about the consequences of cancer treatment. Anthracyclines, like doxorubicin, a huge cause in cancer survivors.
A critical one. And their damage is unique because it's cumulative and it's dose-dependent. They generate these highly reactive oxygen-free radicals, which cause progressive, irreversible oxidative damage to the heart muscle's DNA and mitochondria. The total dose they receive dictates the risk, sometimes years later.
And digging a little deeper into toxins, what about something like hemochromatosis, the H in our mnemonic?
Hemochromatosis is fascinating. It's all about excessive iron absorption and deposition. The iron deposits directly into the heart muscle, and that leads to profound mitochondrial toxicity and fibrosis.
And like alcohol, it can be treated.
It can. If you catch it early and treat it aggressively with phlebotomy or chelation, the cardiac function can often improve significantly.
Okay, let's talk geography. Chagas disease.
Absolutely. Caused by the parasite Trypanosoma cruzi, endemic in Central and South America. It causes chronic inflammation and fibrosis years after the initial infection, and its presentation is so unique it's highly testable.
How so?
It causes DCM, but it often also presents with these GI megasyndromes, megacolon and megaesophagus, and a pathognomonic finding on the echo. An apical LV aneurysm. That combination is it's unmistakable.
The causes just keep coming. Hormonal stressors too. Peripartum cardiomyopathy.
A really specific challenge. It happens during the late stages of pregnancy or in the first 5 months postpartum. The mechanism is multifactorial, but one crucial detail involves oxidative stress and cardiotoxic fragments of the hormone prolactin.
And the stress of pregnancy is the trigger.
The hemodynamic stresses of late pregnancy likely accelerate the failure in women who are already susceptible. Like alcoholic DCM, recovery is possible, but you need rapid, aggressive treatment.
Now let's do one more, a nutritional one that's a perfect contrast. Wet berry.
Berry. Severe thiamine or vitamin B1 deficiency, it's complex. Early on, the lack of thiamine causes systemic vasodilation, which results in a really peculiar high-output heart failure.
High output.
Yeah, the patient has warm extremities and bounding pulses because blood is just rushing through these dilated vessels. But as the heart muscle itself depletes its energy reserves, the pump fails, and it progresses to classic low-output, structurally dilated DCM.
That shift from high to low output failure is what makes it so distinct. It's truly remarkable that all these different pathways end up at the same structural outcome. But what about the cases where we can't find a cause? The idiopathic ones?
Which make up about half of all DCM, and those are very often genetic. Familial cases account for 30 to 40% of the total.
And when we talk genetics, the conversation has to start with Titin,
Right, it has to. The titin truncating mutation, or TTN, is the single most common cause of familial DCM. It's autosomal dominant.
and Titin is that giant protein, the structural scaffolding of the sarcomere. It acts like a spring. So if the scaffolding is faulty, it makes perfect sense that the heart just collapses outward.
Precisely. It compromises the structure from day one. But that raises a question. If the mutation is present from birth, why does DCM often manifest in your 30s, 40s, or 50s and not in childhood?
Which brings us to the second hit theory. Genetics loads the gun, but life pulls the trigger.
That's the perfect analogy. The heart is carrying this compensated structural defect for decades. It can handle baseline life, but it can't handle the stress of, say, a viral infection, chronic alcohol use, or pregnancy. That external stressor is the second hit that accelerates myocyte damage and leads to symptomatic failure.
Which has profound implications for management because you can screen family members.
Exactly. If we find asymptomatic Titin carriers, we can counsel them on avoiding these known environmental triggers. It's a huge piece of preventative medicine.
That's critical clinical advice.
Okay.
We should also quickly highlight two other genetic variants because they have these really specific presentations that scream DCM plus something else.
First, the X-linked dystrophin mutation. The key feature here is that it usually causes DCM in teen or young adult males, and it's often combined with signs of muscular dystrophy.
So muscle weakness, elevated CK levels.
Exactly. Muscle weakness, calf pseudohypertrophy, and those markedly elevated creatine kinase levels.
And the second one, which I know we'll come back to, is LMNA or lamin AC.
LMNA defects affect the nuclear envelope, and while they cause DCM, they're almost pathognomonic for severe conduction disease. We're talking high-grade AV block that requires a pacemaker or a severe bundle branch block. When you see DCM combined with a significant electrical problem, you have to think LMNA,
Why is that so important?
because this subtype carries an extremely high risk of sudden cardiac death.
That connection is a crucial insight. Okay, finally, let's wrap up with management. What are the two main goals when you're treating DCM?
The goals are simple but distinct. First, immediate symptom relief managing all that fluid and congestion. And second, improving long-term survival by stopping and hopefully reversing the adverse cardiac remodeling.
And which drug classes actually improve long-term survival?
The cornerstones are the drugs that block that detrimental neurohormonal activation. So ACE inhibitors, or ARBs, to reduce afterload and remodeling, and beta blockers to slow the heart rate and block sympathetic overdrive. These are the medications proven to halt and potentially reverse the progression of eccentric hypertrophy. They are mandatory.
So if ATE inhibitors and beta blockers handle survival, where do diuretics fit in? Because you hear about them all the time in heart failure.
Diuretics, like furosemide, are essential for acute symptom relief. They reduce the congestion, the edema, and they make the patient feel better quickly. But, and this is a vital distinction, they do not reverse the remodeling process or offer any long-term mortality benefit. They are purely for symptom management.
And for those patients who progress despite all that medical therapy, what are the advanced options?
When the EF stays severely low, the risk of fatal arrhythmias goes way up. An implantable cardioverter defibrillator, or ICD, is indicated for primary prevention of sudden cardiac death if the EF is at or below 35% despite months of optimal medical therapy.
And the final step.
For true end-stage refractory DCM, heart transplantation remains the definitive cure.
So we have completed the journey of dilated cardiomyopathy, the heart that chooses eccentric hypertrophy sarcomeres in series to cope with volume overload, ultimately creating that high-stress floppy balloon. And we've seen how all these disparate triggers, from viruses to genes, all use the single pathway to cause catastrophic failure.
Understanding that underlying physics, that structural choice the heart makes, is really the key to differentiating DCM from everything else.
And to leave you with one final high-stakes piece of knowledge from our sources, remember that critical genetic presentation. The combination of DCM, a family history of sudden cardiac death in young adults, and any significant electrical disturbance like a high-grade AV block.
That should immediately make you suspect the LMNA mutation.
Recognizing that specific link between a structural envelope failure and severe conduction disease is so crucial because these patients need aggressive monitoring or device therapy for fatal arrhythmias.